Hello, everybody. Welcome to another BTOG podcast. And this is a podcast you can also just listen to, or you can see it on your phone as a visualized podcast. This time, we're focusing on the updates and highlights of ASCO 2026. So ASCO is the large American meeting held in Chicago every year and is one of the premier locations for release of new data in all cancers and relevant to us, lung cancers. So I'm delighted to be joined by two colleagues to help discuss the top line data. We're going to have 5 major abstracts and 4 minor abstracts. I'm joined by Dr. Joanne Evans, who is a medical oncologist at Imperial College London hospitals, and I'm also delighted to be joined by Adam Januszewski, who is a medical oncologist at Bart's Cancer Centre. And we're going to go through these one by one in a way we're going to discuss a little bit of the data, and then we're going to go through a little bit about the side effects, perhaps, and discuss the significance of them. If you do have access to video aspect, when there is a slide to look at, for example, an overall survival curve, we will flag that to you. If you're just listening to it, then I hope the discussion itself will be enough for you to understand and enjoy what we're going to go through. So Adam, Joe, welcome, and thank you very much for joining me today as part of this. The first study we're going to go through is the Harmony-6 study. Now, the Harmony-6 study was one of the major abstracts that came out in one of the plenary sessions, and it is looking at antibody-drug conjugates, and in particular one targeting PD-1 and VEGF. And this is important because it's a drug called ivonescimab, which has had a lot of interest over the past few months and indeed a couple of years. And there's been a number of studies coming through, and ivonescimab is looking in one particular study here, Harmony-6. So Adam, tell us a little bit about the headline data on Harmony-6, if you could.
Thanks, Tom. Yeah, so the Harmony-6 was a phase 3 randomized study looking at, as you said, ivonescimab, which is a PD-1 VEGF bispecific, compared to chemotherapy and an immunotherapy that's more frequently used in China called tislelizumab. And this is, as you would expect, an induction with 4 cycles followed by maintenance. What we've seen on this anticipated results was that there was a significant improvement in median overall survival from a 23.7 months through to 27.9 months, with a hazard ratio of around of 0.66. So really one of the first regimes to show superiority over an active PD-1 inhibitor. But of note, this was, as I said before, in a Chinese population. But when we look at all the different the stratifications, we could see that there appeared to be benefit across the PD-L1 spectrum, both positive and negative. And there were expected toxicity profiles with an increased number of those around the VEGF inhibition aspect of that bispecific. And the results were published in the Lancet when the presentation was announced. So what did you think of that data, Joe?
I thought it was quite interesting. I mean, for me, there were 2 main things that struck me. So one is the question that we always ask when we hear new data and new compounds is this a challenge to our standard of care? Have we finally come across something that beats PD-1 chemo as a first-line strategy for advanced squamous non-small cell lung cancer? And I think that if you delve down into the data, a 4-month overall survival benefit is meaningful. But then when you compare the standard of care to other regimens that are reimbursed or licensed, or if you have a look at actually the Rationale 307 study, which is the study of tislelizumab with carboplatin and paclitaxel in squamous disease, actually the median overall survival there is a little bit better than the standard of care arm in this trial at 26.1 months. So, what accounts for that difference in terms of patient selection? And is it really meaningful? Is that 4-month survival benefit genuine? And then I think the second kind of point for me is the one that we always come down to, especially after big congresses, is, this is a China-only data set. Is it applicable to a Western population? And I think we'll get those answers from the phase 3 Harmony-3 study.
Do you think we're being a bit harsh there, Joe? I mean, we saw data from this study last year. It said progression-free survival was positive, and we all said, well, it's progression-free survival. You've got to have overall survival. They've now got overall survival, and we all say, well, we now need to have global data. Is that a fair criticism, or do you think there's some prejudice going on here?
And I think it's a fair criticism. We have seen trials where that are being conducted in non-global populations, where actually on in the big global phase 3, the results are very different. If we're going to potentially give this to our patients, I think we need to know that we're doing the right thing.
Yeah, and so I think if you look at squamous populations in China and outside of China, there are demographic differences in them. Sorry, Adam, I cut you off there.
Yeah, no, and I think there were some inconsistencies that we saw in this study. We saw that there was actually an underrepresentation of an older patient population. There was this inclusion-exclusion, which excluded kind of tumours that were invading vasculature and largely necrotic. And actually, when you looked at those individuals that were included in the study, it included those. So there were some inconsistencies. And when we look at the because there is a phase 3 global looking at this, some of the PFS data doesn't seem to be matching what we see here. So I'm still waiting to see, I suppose, what the global study looks at in the squamous population, because of that kind of that VEGF inhibition and that historical issues around using it in individuals with squamous cell cancer.
And what about side effects, Adam? I mean, we've had an increase in overall survival. That's great. That's welcome. Has it come at significant cost?
Well, not that's reported through this study. There were some minor grade toxicities around the VEGF inhibition above that. We've seen the immunotherapy, for example, blood pressure and proteinuria, but actually not that was unexpected, and not enough, obviously, to derive a signal that would be inferior in this study.
Yeah, so, I mean, I think it's an interesting study. I think we do need the global data. I agree with Joe. But I do think ADCs are interesting. I do wonder the slightly overexcitement on what's not necessarily a new target. But I think given the global population in a comparator to perhaps more established regimens, there is still that OS benefit. I think that is impactful. So we will move on to our second study, and Joe's going to go through this. And just to remind people, when Joe or Adam mention a slide, that means that is visible on the video part of the podcast if you have access to that. We're going to focus on a study called Wukong 28. Now, this is a study we've also discussed in a couple of conference highlights over the past year or two. And this is very interesting. This is for a drug called sunvozertinib, and it's in exon 20 insertion non-small cell lung cancer. So the rarer, the atypical exon 20 insertion mutations. And there's been many drugs which have previously been tried in this setting. And there are some new drugs coming through as well. And UK listeners will or may know that recently we've had approval of the combination of chemotherapy and amivantamab in the Papillon regimen for this indication. But here, Joe, we have sunvozertinib in the first-line setting. Tell us what you thought about this study.
Again, I thought that this was an interesting study, and we'll probably get into some of the details of why. But as you can see from this first slide, it was a randomized 1-to-1 trial looking at sunvozertinib 300 milligrams once daily versus platinum-based chemotherapy. I think it's really important. I've shown the study design because, as you can see on PD, patients could switch on to sunvozertinib if they had chemo, and actually 90.2% of patients did this, which may compromise our overall survival data, but we can discuss that a little bit later on. The primary endpoint was progression-free survival as assessed by blind independent central review. There were 324 patients allocated and randomized. If we have a look at the next slide, this shows the progression-free survival, so the primary endpoint. And as you can see at the 18-month landmark, 33.2% of patients were alive without a progression event on the sunvozertinib arm compared to 17.1% who had chemo. I've also on this slide included the second progression-free survival, the PFS2, because as I've said, quite a large number of patients crossed over onto sunvozertinib. And as you can see here, 18 months down the line on PFS2, 56% of patients on have stable disease on the trial drug compared to 44% receiving chemo.
So, I mean, this is clearly showing superiority in terms of activity. I think that's great to see. We love seeing that. Do you want to tell us a little bit about toxicity whilst we're on the data side, and then we might ask Adam what he thinks, his thoughts on the data?
Absolutely. So the toxicity is probably unsurprising for something that is targeting an EGFR picture. And actually, the main toxicity from sunvozertinib is diarrhea, with 84% of patients having diarrhea. 13.4% had grade 3. The other toxicities encountered are probably as you'd expect. So CK elevation, rash, and paronychia, really, really common. As compared to the chemotherapy arm, where obviously these weren't seen so commonly. So kind of on what you'd expect really from a EGFR directed therapy, with the exception that the diarrhea rate was really quite high.
Yeah. Adam, what do you reckon? Are you sold by this? I mean, we need new treatments in exon 20. Do you think this is a winner compared to chemo, AMI? Is it better than chemo alone? What's your thoughts?
Yeah, I mean, it's a very good point, Tom. I think that these results are impressive, and that was represented. In fact, they was published simultaneously in the New England Journal of Medicine. It shows a promising response. I think the depth of response that you see with this as a single agent monotherapy or targeted therapy is good. It's clearly comparing to chemotherapy doublet, which is the standard of care, but one could argue that actually, with the advent of AMI chemo, that potentially it's a historic control.
Yeah.
But also, I suppose, moving forward, you saw this impressive PFS, but it's not really playing out into the overall survival. And while that's disappointing, it's actually, I suspect, as a result of two things. One is the data is still immature, but also this really high crossover, 90.2% crossover, which therefore dilutes that overall survival benefit, it's unlike many studies these days. Actually, you don't often see the ability to cross over to an active compound. So it's good for patients because all patients in this study got the drug, but actually I suspect it's clearly diluting that OS. I suppose the only thing to pick up was the toxicity profile. I mean, if we have standard of care at the moment in the UK being AMI chemo, that has a raft of different toxicities. This, 84% had diarrhea of some description, lower grade, but diarrhea can sometimes be a difficult toxicity to manage, particularly if you're on this tablet for a durable amount of time.
And one thing that struck me was there was no CNS data presented, so no brain-controlled data. I've used this drug in a few people, and anecdotally, I do have concerns about brain protection. So I think I'd like to see that, and I'd agree with you that I think the diarrhea is something to watch out for. It reminds me a little bit of the kind of second generation EGFR inhibitors we were using 10-15 years ago. So yeah, I agree with you. I think this is a really interesting agent. If it were available, I think I'd certainly would discuss it as an option. There are other drugs in this field, as they say. So we've got zipalertinib, which is in trial as part of the Resilient-3 study. And we've also got fomanertinib as part of the Fervent study. Some of those are alone as first-line therapy, some in combination with chemo. So interesting to see. But I think this is an agent which is much needed in exon 20 insertion lung cancer. And we look forward to some of the more mature data coming through. So we will move on to ALK. And we will move on to the ALCOVE study. And the ALCOVE study is following a drug called neladalkib, which is made by Nuvalent. And this has been something which has been showing bits of data on and off here and there for a while. And we've got an update on the ALCOVE-1 study. And Adam, I think you're going to tell us a little bit about this. Why is it important? Because ALK is one of the most treatable lung cancer types we see. We are getting clarity about the best first-line treatment. And here we have some data on a next-generation drug, both in first-line and relapse setting. What's your thinking, Adam, on the data?
Yeah, so neladalkib, as you said, this is part of the ALCOVE-1, which is a phase 2, 1-2 global single-arm study. What we saw in this relatively large cohort of patients is that we saw data both in the TKI pre-treated and actually some early data around TKI naive population. And when we look at the data, which you can see in the slide if you're watching, we can see some quite impressive results, but in the TKI population with overall response rates of around 86%, with a median duration of response rate of about 91% at 12 months, with what would appear in small numbers to have quite CNS control, good control. In the larger population of that with the TKI pre-treated, we saw an overall response rate of around 31%. And when you drop down that and look at those that had lorlatinib exposure before, that comes down to 26%. So you can see, obviously, we already have lorlatinib, which is a highly effective TKI. And the question here is whether neladalkib can be sequenced beyond the use of lorlatinib, which is already very effective. Yeah. One of the smaller populations that they looked at, which is one of our most common resistance mutations, was that in the G1202R subgroup, and that actually showed some very excellent activity in overcoming some of those response in those individuals.
Yeah. Joe, what do you think about that data? I mean, this drug has been trailed for a while. We're very excited. We want new agents. Were you overwhelmed or underwhelmed by the data, or were you jury still out?
I mean, I think the first thing to say is post ASCO, this has now been given FDA priority review with the result due in November of this year. So I think the data is meaningful, and it's also a drug that patients come to clinics specifically asking about and asking how they can access it and when they can access it with the open compassionate access scheme within the UK. I think it is interesting. I think you can break it down into the two cohorts. So you can look at those prior TKI exposed patients. And actually, if you look at that response rate, if you look at the patient population that didn't receive lorlatinib, the objective response rate is 46%. So for and the average number of lines a patient had was 3. 80% of patients had at least 2 lines of TKI before accessing this. And I think that result is nice and meaningful, but it is important to say that only 9% of patients in the study were in that lorla naive category. So it is small numbers. It comes down to 25, 30 patients. So I think that definitely warrants further investigation. The other stuff, the other thing to look at really is, I think the really nice thing about this drug is it's TRK sparing. So if you look at toxicity and you look at, the whole space, we've got really, really, really good options now that, we've seen the CROWN data, we've seen the 7-year data, it's mind blowing. And, this looks comparable in the TKI naive setting. If you look at kind of minimizing those CNS toxicities that you get with TRK, it kind of brings to the forefront, what is the right treatment? Is it the one that is best on paper, or is it the one that the patient can tolerate for longer and stay on for longer? So I think that, the toxicities of these treatments are now going to become, more important in our decision making as compared to, having access to either alectinib and brigatinib versus having lorlatinib. I think this is a real challenger for lorlatinib.
I agree. I don't know. One thing struck me when I was in the auditorium listening was, if you look at the lorlatinib prior treated patients, and I think we're going to have to assume that that's going to be all of our patients in the future, the median progression-free survival is only 4.6 months. Did you think that was not bad given the scenario, as Joe said, heavily pre-treated, or did you find that a bit disappointing?
Find it disappointing. Because we always want longer. However, we know these individuals we've all seen these patients in clinic, they progress quite quickly and have quite aggressive disease quite often when they progress on lorlatinib. So I think 4 months is a median, so you will have some of those longer term survivors as part of that Kaplan-Meier. So I think maybe it's about selecting the patients better rather than necessarily saying this is an active compound. And like you said, Tom, the the bar is so high with lorlatinib that it's difficult to pip it. So it is around that toxicity profile that whether we can, as with many other TKIs, whether we can not necessarily improve efficacy, but actually improve the tox profile and therefore tolerability.
I think that's absolutely right, and we should remind people that the phase 3 ALCAZAR study, which is first-line study, is going on at the moment. I'd like to see a little bit more data from ALCOVE-1 on the neuro cognitive side effects, which we know are a problem with, for example, lorlatinib. So that's very interesting, much excitement there. We're going to move on to OPTITROP, continuing our excellent name of studies. OPTITROP is very interesting. This is, to my mind, one of the most interesting antibody-drug conjugates that we are seeing in lung cancer. We've seen a few OPTITROPs. We've seen OPTITROP-3 and OPTITROP-4, and this is OPTITROP-5 of sacituzumab TMT in first-line PD-L1 positive non-small cell lung cancer. Joe, you're going to give us a little update on the data that was presented on OPTITROP-5.
Yes, so OPTITROP-5 was a randomized multi-center open label phase 3 trial, and as you can see from the current slide, randomized patients 1-to-1 to receive sac-TMT at 4 milligrams per kilogram every 2 weeks, with a backbone of pembrolizumab 400 milligrams every 6 weeks compared to pembrolizumab on its own. The primary endpoint was progression-free survival as assessed by BICR, and secondary endpoints included overall survival, PFS by investigator, objective response rate, duration, and safety. Stratification factors were histology, so squamous versus non-squamous, with PD-L1 status, so PD-L1 of 1 to 49% versus above 50, and performance status 0 to 1%, 0 to 1. So as you can see in the next slide, then we have that primary endpoint, which is PFS by BICR, and as you can see here, there is at 10.5 months, actually, the median progression-free survival was not reached for sac-TMT compared to 5.7% for pembrolizumab. And then if you look at the 12-month landmark, you can see patients that got sac-TMT plus pembro, 62.4% of patients are alive without a progression event compared to just under 30% for patients that had pembro alone.
That's pretty impressive data there. I mean, that's an improvement in its primary endpoint. It's met its overall response rate. Joe, you must be ecstatic. What other data can you show us, or are you going to let us down with some toxicity data?
So there is a bit of toxicity data, as you can see on this slide, and the grade 3 TRAEs were higher with sac-TMT, but interestingly, discontinuation rates between the two arms were quite similar. So you can see here the main toxicity of sac-TMT are anemia, neutrophil count decreases, so neutropenias, stomatitis, ocular surface toxicity. So, you know, having a friendly ophthalmologist is quite key. And then infusion related reactions compared to the standard, you know, toxicities we've all come to know and love from pembro, your hypothyroidism, your pneumonitis, your infusion reactions.
Yeah. Okay, so we've got activity, we've got clinical activity. We do have some side effects, but that's not unexpected in ADCs. Adam, you know what I'm going to say to you? I'm going to say to you, do you give single agent pembrolizumab to all your PD-L1 positive patients? Is that an appropriate comparator for this study, or have we managed to confuse ourselves by not quite knowing what we're comparing to?
Yeah, I think you're absolutely right, Tom. I think that sacituzumab tirumotecan is one of the leading TROP2 ADCs, and we've seen it rolled out both in Chinese and global studies. This is a Chinese only study, and as such, the control arm here really isn't representative of what we would give as standard of care. So there are some caveats. And I suspect what we see, and like you said, the PFS looks great. The hazard ratio is great. We've got good separation of the curves. But when you look at the PD-L1 status and boil it down, actually the greater benefit is seen as though PD-L1 negative, whereby you would argue that actually the control arm here is underperforming because they're not receiving the standard of care. So I think there's that, which needs further clarification. I think clearly it's a very active compound. Clearly in the PD-L1 high, it derives additional benefit to kind of immunotherapy alone. But there's also a couple of other caveats that I think that we need to look to bear in mind. One is there's a 14 to 20% never smoking population in this population, which again needs to be taken with a caveat, because obviously if there's large numbers of drivers, often individuals don't get as much benefit. So I think it looks positive, but I think we need to wait for the TroFuse studies, which are those for sacituzumab tirumotecan in the global studies, to really understand the order of benefit that this brings. But I have no doubt that this would probably be a changer for us, but we need the right data.
Yeah, I agree. I think it's a run of rare. It is. I don't think it's ready for prime time yet in our local clinics, but we look forward to seeing some global data. And so our fifth and last major study, as we might call them, is LORIN. Now, LORIN is focusing back on ALK again, and this is perioperative lorlatinib in ALK-positive disease. Colleagues will know that in the EGFR space, we routinely use adjuvant osimertinib. In ALK, we routinely use adjuvant alectinib. And there's been some interesting data about neoadjuvant osimertinib in EGFR. Here we have perioperative lorlatinib. Now, there's been a couple of other studies looking at this. In case you're thinking, I'm sure I've seen this before, you're sort of right. We've had the ALNEO study, we've had the Nautica-1, which have shown neoadjuvant alectinib and perhaps slightly disappointing pathological complete response rates. So here we have what is probably the most effective ALK inhibitor, certainly in the first-line setting, testing itself in the perioperative setting. Joe, I think Adam, you're going to go through this one. Tell me a little bit about the study and what was found.
Yeah, so this is a phase 2 study, ALK-positive patients. So it's only small numbers, 43 actually had treatment in the end. It's a Chinese population. And I think it's important to consider the trial design here, because it was whether they were resectable or potentially resectable stage 3 disease. And if they were one of the others, they were then given lorlatinib for 3 cycles before reassessment for then resection. And what we saw, whether you were in that resectable or unresectable cohort to start with, 75% went on to then be fully resected. And actually, when we look at the R0 rate in the cohorts together, there was quite good surgical selection. Around 97% had an R0 resection. So good selection of patients. And then the patients went on to then receive a further 2 years of essentially adjuvant lorlatinib. So really that perioperative approach, which we're seeing elsewhere. And those that were not resectable, there were various different reasons that were using. Bearing in mind these are small numbers, there was sometimes patient choice that decided they didn't want to go for surgery, and also those that then proceeded on to radiotherapy when they were no longer resectable. But ultimately, the headline figures in this case is that those that went to surgery, 47% achieved a pathological complete response. So really quite impressive figures. And then when you include the major pathological response, that goes up to, that's where you've got less than 10% of viable tumor, that goes up to 81%. So 8 in 10 patients managed to receive less than 10%. So really quite impressive data. And as part of this presentation, they also did some really interesting translational studies, because it's one of the few opportunities you've got to do one of these window of opportunity studies to see where our early resistance mechanisms are developing with lorlatinib, and certainly they presented some interesting data around that.
Absolutely. So I think clear activity. Joe, I mean, the number quoted, the PCR rate of 47%, actually someone pointed out to me, I know I didn't spot this, but someone else did, actually it's a little bit lower, the intention to treat PCR rates actually in the high 30s, but it's pretty good, right? It's better than we've seen with alectinib. It's at least, it's almost double that. What did you think about that PCR data, and what did you think about the fact that 25% of patients didn't get surgery? That's quite high, isn't it?
Well, I think when you consider the population they were looking at, so these were people that were potentially resectable. So again, borderline resectable or unresectable. And it transformed 75% of patients to being resectable. I thought that this was a really nice study, and this was my standout abstract from ASCO personally. And it's all around that kind of major pathological response, that 81% I think is phenomenal. If you look at, take parallels to the breast world, where they've been using PCR and MPR as kind of surrogates for, have we actually cured someone without steel? I think that this trial is really meaningful. Is an MPR of more than 80% effectively curative intent treatment before anyone's got anywhere near a surgeon or a clinical oncologist? The other thing, I think, when you've got a drug as active as lorlatinib, this probably isn't a surprise. Should lung cancer with actionable genomic alterations and a really good drug be seen as a systemic molecular disease rather than a surgical problem in the first line? Should all of these patients be having TKI before surgery? I think it raises some really interesting questions, but given the population was borderline resectable or unresectable, I think the data is amazing. There were no progression events in the neoadjuvant period, which again, I think, you consider what we do to patients without drivers, and we get excited by a 24% pathological complete response rate. I think these results are amazing.
So Adam, Joe sold. That's good to see.
Yeah. Easy.
Are you? Can we look at that PCR rate and say, "Oh, that's fantastic. This will translate into survival," or do you need to see survival? If you could have access to this drug tomorrow in the perioperative setting, would you use it, or would you say, "Show me the event-free survival data. Show me the OS data first"?
I think I need to see the data, absolutely, because our data for metastatic disease with lorlatinib, as we'll come on to discuss shortly, is really quite convincing. And as such, it does make me wonder what happens with patients with advanced disease, and which proportion of our patients are getting PCRs in the advanced setting is number one. And actually, two, you still need to see the OS data related to this, because are we doing these patients a service or a disservice? And also adjuvant therapy for 2 years, we just need larger data sets to be able to do this.
And actually numbers here are quite small, reflecting the so we look forward to that. But I agree with Joe. I thought this is really, really interesting. And I hope it has the same positive outcome in bigger studies. And I also agree that if you've got someone potentially resectable, given the nature of this disease in the young patient group, you want to explore surgery in that patient if you can. So I think it was good stuff. So we're now going to move on to our 4 minor ones. We're going to be much more superficial, just very brief chat of the data. And the first was the CROWN data. So we've seen the CROWN data. This is first-line lorlatinib versus crizotinib. This is a 7-year update. It's extremely unusual to have such long updates. But Joe's going to tell us why we're going to have 7 years worth of data in this study.
Yeah, okay. So I'm going to cheat. I was told for the minor abstracts 1 slide, but I have 2. The first slide I wanted to show you, I know, right, is the progression-free survival in the intention to treat population. And you can see here now at 7 years, patients who got lorlatinib, 55% are alive well without a progression event, compared to 3% of patients who got crizotinib. I think that this is mind-blowing. So we've previously heard the 5-year data. In between the 5-year data and the 7, there have been 4 progression events in the lorlatinib arm and 3 patient deaths, none of which were treatment related, so presumably related to disease progression or other causes of death. What I think is really, 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 really amazing with this data is patients without a progression-free survival event in the first 24 months have a 79% probability of being alive and disease-free, progression-free at 7 years. 80% of patients that get to that 2-year landmark. I think that's amazing. And then obviously the initial excitement around lorlatinib in the metastatic arena was the CNS protection. So that's the other slide I've got here. So time to intracranial progression in the intention to treat population. And you can see here, since 36 months, that has stayed steady at 92%. So therefore, if you get a patient to 3 years on lorlatinib and they do not progress within the brain, are they, have we induced a a complete pathological response, as Adam alluded to
very
with
strong.
the LORLA data. So I think that this is really, really lovely data. In terms of toxicity, there are no new toxicity signals outside those that we've now come to know and love from using lorlatinib.
That's very, very helpful. Thank you very much. So, Adam, the efficacy is not in doubt here. A couple of questions for you. Given that amazing CNS protection, if you haven't got a brain metastasis, do you think there's a role for not doing brain surveillance? Do the first, I don't know, 6, 12 months, and then stop doing brain scans because the chance of having a brain met is incredibly small on this drug?
Yeah, I think it's a very good point, Tom. And I think that if you ask 10 oncologists, they'll give you 10 answers. I think the data is very clear that you don't get CNS progression, so you can certainly support the reduced frequency of brain imaging, whether that's once a year, once every other year, I think, or on symptoms. I think that there is. I think this data, as much as it hasn't changed much from the 5-year data, I think it helps that conversation that we have with patients. It helps that conversation both up front and when you're 2 years in, and also that reassurance for patients about having brain mets. You can reassure them with this data very clearly around that. And I think the other thing that was interesting around some of the data here is they showed some of the outcomes for dose reductions. And actually, while the data was small, there was some interesting data where actually with dose reductions, it doesn't impact the efficacy data. So I think both of those things, as much as the data hasn't changed much in 5 years, it is probably our best drug in lung cancer, and we should celebrate that and put it on the stage for 7 years and then 9 years and then 12 years.
That's
does make
someone's
me
career,
fearful
mate.
for waiting for that progression, that overall survival from the LORIN study. I think we're still going. I think we'll have retired.
Yeah, which would be a nice thing. I agree. I think that dose reduction data is really important, and I've used that a lot in clinic, saying to people, if I dose reduce because toxicity, it does not appear to impact on efficacy. I agree with Joe. One of the nicest bits of data is to say when you get beyond a certain point, your chances of having long-term survival on this are much better, and 18 months is roughly where that is. Okay, so we're going to move on to adjuvant selpercatinib. So Adam, you're going to give us a brief overview. This, to my mind, slightly surprisingly got into a plenary abstract. So we know that adjuvant EGFR TKIs work. We know that adjuvant ALK inhibitors work. And in this study, we were going to survive. Were we surprised to find out that adjuvant RET inhibitors, selpercatinib, works? Adam, what was your take on the data?
Yeah, very good point, Tom. And I think the reason why it was is because this is such a rare group of patients that actually we should celebrate getting that number of patients in the adjuvant setting, whereby these are often never smokers that you wouldn't pick up early stage disease. So it's a celebration to the team that ran this trial to really get this over the line. So this is a phase 3 called Libretto-432, utilizing the use of adjuvant selpercatinib after definitive treatment in stage 1B to 3A RET fusion positive lung cancer. And that definitive treatment could be radiotherapy or surgery followed by adjuvant chemotherapy. So there's a mixture of patients in this population. And what we see, and you can see in the slide attached, is that we had an event-free survival, which had a hazard ratio of 0.17. With a p-value of 0.0003. So really separation of the curves, 31.8 months versus not reached. And when you look at that 2-year event-free survival, 91.5% with selpercatinib versus 61% on the placebo controlled. So really, really positive results here discussed at the plenary. And I suspect this is, while the overall survival data was not mature, I suspect this should really be a change in practice for us.
Yeah, absolutely. I mean, that's an extraordinary hazard ratio. 0.17, I mean, it's quite remarkable. Clearly active. Joe, if you had access to this, would you be giving adjuvant selpercatinib if it was reimbursed?
It would be a discussion to be had, wouldn't it? I think the thing that struck me really was the toxicity. So obviously it's easier to justify giving a patient toxicity if they've got metastatic disease, but these are patients that have been radically treated. Grade 3 side effects in the SALPA arm were high at 67% and a discontinuation rate of 17.3%. And obviously that is in part because of the how long patients were on treatment for. It was planned for 3 years of therapy, but I thought that was quite high, and the main toxicities being liver dysfunction and hypertension. And then I guess we've touched on it with a couple of the other abstracts, and it's the conversation that we had with the initial ADAURA data before we saw the overall survival data. People will cross over, people will relapse, and they'll get a RET inhibitor, as their first line metastatic treatment. I don't know if we've actually shown without survival data if using a drug earlier saves more lives than using it at relapse. So for me, I guess. And that was the big debate with the ADAURA data. I remember Twitter was a bin fire with people saying this is meaningful, it's changed practice, and people saying no, it hasn't until we've seen that overall survival data. So I think it's really interesting, and clearly it works and it has activity. And then I guess the final thought is around, AGAs and adjuvant trials. Do we need another one, or have we proved the concept that bringing these drugs in may give people better quality of life by delaying their relapse?
Very good point. Okay, so to my mind, I'm sure that's going to show OS benefit in due course. We'll move on to our penultimate abstract, which is the use of amivantamab lazertinib in atypical EGFR mutations. People on the listening will probably know that ami-laser is reimbursed and licensed in the first-line treatment of common EGFR mutations, exon 19 deletion, and L858R. But this is looking at the atypical mutations, and this is an often neglected group, actually. We don't have that many agents for them. You can use afatinib for these patients. I would advise against using osimertinib, which tends to be much less effective than afatinib for most, but not all atypical mutations. Joe, we've got data on ami-laser. This is part of the CHRYSALIS-2 study, which has had various cohorts. This was cohort C. What was the top-line data on the ami-laser in atypical EGFRs that caught your eye?
Okay, so the primary endpoint was objective response rate via RECIST 1.1, which is what we're currently showing on the screen at the moment. So you can see here that it has activity. The vast majority of patients, all patients either had stable disease or a partial response. And the median duration of that response was 20.7 months and a median PFS of 19.5 months. Which I think is possibly meaningful. You've already alluded at the moment these patients would almost certainly get afatinib, which is perhaps not quite so toxic as ami-laz. However, does have the paronychia and rash associated with it. But what I was really struck by was the landmark overall survival, which at 3 years is 55%. I'm trying to think of my atypical patients, and I can't remember that many of them that have made it to 3 years. So I think this is nice data.
Yeah, the OS data, so 41 months for ami-laser versus just under 20 for afatinib. I mean, cross-trial comparison, all the risks that come, but it's clearly active, isn't it? And appears to be more active with all those caveats than afatinib, but comes at a cost of side effects. We all know what those are, and maybe in the interest of time, we may not focus on those. Adam, what's your thoughts on ami-laser for the atypical EGFR mutations? Are you convinced by that data?
I am, yeah. And within the presentation, they presented the pooled data from a larger data set of primary choice first-line TKI. And you could see while there was an overlap for the first 6 months, actually separation beyond that. So really demonstrating the additional value of that combination. And this is an area of high unmet need that I think you will struggle to get large phase 3 randomized studies to demonstrate impact like this. So I think it clearly is an active compound. I'd like to see it taken forward.
Great stuff. Final abstract goes to you, Adam. DELLphi-304. This is tarlatamab in small cell lung cancer, which is discussed in previous podcasts. One of the most important drugs, I think, in small cell for quite a long time. They presented some brain data, some data on CNS activity. Give us an update on that if you could.
Absolutely, Tom. And I suppose this is just one of so many small cell presentations at ASCO this year. I can't remember how many there were, but it's a really quickly moving space. So this, as you said, was the use of tarlatamab in DELLphi-304 study, which was a randomized study of those individuals with small cell lung cancer who've progressed after first-line platinum-based chemotherapy. And they were randomized to tarlatamab, which is a DLL3 bispecific T-cell engager, versus standard of care chemotherapy. And this data set was really to look at the activity in a subgroup of patients that had brain disease, because they were allowed, individuals with brain mets were allowed in this study if they're either asymptomatic, treated, or untreated brain mets were all allowed. And this is often a cohort of patients which are challenging to treat. And what we saw is quite convincing CNS activity. When you look at the CNS progression in those in tarlatamab versus the chemotherapy, the hazard ratio is 0.54, with very clear separation of the curves at the very early part of the disease, where the median CNS PFS was 7 months compared to not yet reached. And when you drill down to some of that data, there's some patients getting a complete response in the brain. So 15% almost got a complete response on tarlatamab, which is, it's just out of kind of keeping with what we would expect with a large molecule crossing the blood-brain barrier. So really, it did really demonstrate some really positive activity in the brain. And not only that, is that the presenter overlaid those individuals with brain mets and without brain mets, and demonstrated that where traditionally brain mets confers to a poorer outcome. We saw that within this study for the chemotherapy arm, but actually what we see with the tarlatamab arm is those individuals with brain mets had no inferior outcome compared to those without brain mets.
I mean, we've never seen that before in a small cell. I mean, that's extraordinary data. It's quite a small graph, and it kind of passed people by. But I agree. I think it was one of the most remarkable things we saw in ASCO. I mean, who would have thought you got a drug where if you have brain mets, your prognosis is not worse in the small study? It's great stuff. Joe, were you as excited as me?
Yeah, no, I think it's lovely. I think I had two thoughts. One of them is slightly cheeky and maybe naughty against my clinical oncology colleagues. But when chemo atezolizumab became standard of care, we were joking with our clinical oncologists that we didn't need them now to deliver consolidated radiotherapy because atezolizumab leveled the playing field. And now I'm wondering if we need our neuro-oncologists to manage our patients' CNS disease.
There we go. It's always nice
Scandalous. Yeah, absolutely. But I mean, we're seeing a lot of these agents now that do have CNS penetration and activity. And I'm wondering in small cell, actually what should be the primary endpoint in these trials? Should it be looking at intracranial objective response rates? Because actually we know that it's the brain metastasis that drives prognosis and survival in small cell. And if we've got compounds that prevent that from happening, then hopefully that translates into better overall survival and less side effects from radiotherapy.
Yeah.
And there's a really good reason to include individuals with brain mets on studies
Absolutely.
that also have not had treated as well, because some of the study designs do a bad service to themselves, because then they don't include brain mets. Actually, we don't know the activity of their compounds within the brain. So it's a really nice study, and it shows that activity.
Adam, quite right. You have the last word, and I think that's a very fair summary. So those are our top 5 majors: Harmony 6, Wukong 28, ALK-1, OPTITROP-Lung05 and LORIN. And our minors are the Crown data, adjuvant selpercatinib, amivantamab lazertinib in atypical EGFRs, and DELLphi-304 brain data. So we will leave it there. I'm going to make one other comment, which is it hit all the newspapers about the data in pancreatic cancer. This is obviously not a pancreatic cancer podcast, daraxonrasib, but it won't have escaped many of your notice that this is a drug which is targeting KRAS G12X mutations. It is in clinical trials in across the world for lung cancers with carrying that mutations. Joe, first, are you optimistic for that drug? Do you think we're going to see activity in lung cancer?
I thought that the plenary was amazing, and I'm so glad it was straight after the lung sessions because we were in the room, right? I mean, to have a 55%.
People in tears.
Yeah, it was. Yeah, I was sat next to a very emotional American lady. I think like at the 12 months landmark, 55% of patients that got the KRAS-on inhibitor were alive without progression compared to 17% of patients on chemo. Mind blowing. And we're seeing this more and more that actually, your KRAS doesn't act differently because it's sitting in a bowel cancer compared to a lung cancer compared to another cancer. So I think that this is really interesting. Can't wait to see the lung data.
Yeah. And we're equally excited. I mean, that there was a little bit too little focus, I thought, on side effects. I mean, it's not a benign drug. Rash is an issue with it. So active, but we probably need to have a little bit of calmness and see what the data really shows, right?
Yeah, it's a good point. It does have toxicities, but not out of keeping with the other KRAS-directed therapies. I am very excited by it. Obviously, we have the first phase 3 in lung cancer randomized in the second-line setting, and I think the question comes is, should we be targeting individual RAS receptor mutations, or should we be taking a pan-RAS approach?
Yeah, absolutely right. Very exciting times, and maybe we'll be discussing that in 2027 ASCO update. So I'd like to thank everyone for listening. I'd like particularly to thank Adam and Joe for heroically going through abstracts whilst jet lagged on the return from ASCO. These are difficult asks when you get the email saying, please, can you do the ASCO update? It's not easy to do. I hope it's useful to all of you listening, whether you're just listening or seeing us as well. I hope you'll join us for our next podcast in about a month's time. Thank you, Joe and Adam.
Thanks.
Thank you.